Dear colleagues, thanks for the invitation. It's a pleasure for me to be at this meeting virtually. I want to present you my personal experience about the micropulse TLT as a standard of glaucoma care. These are my financial disclosures. Some are related to this talk. And let's look a little bit at the personal experience and data that I have with the MP-TLT. First of all, the MP-TLT, other than the continuous wave treatment, fits for me in the treatment algorithm for glaucoma at numerous positions, sometimes as an alternative to ALT or SLT, so to laser trabeculoplastic, in the huge gap where also the mixed procedures fit before we do trabeculectomy. During the COVID times, when a lot of my patients refused to undergo trabeculectomy, I learned that micropulse could be not an alternative to trabeculectomy, but at least a treatment we can offer our patients who do not want to have a trabeculectomy to lower their IOP in the meantime until they feel safe again during the pandemic times to undergo a real surgery. And it definitely is also an alternative to cyclodestructive photocoagulation. So my personal results that I have for the MP-TLT, and we looked at these cases retrospectively, 47 eyes in the beginning we included, most of them were primary open-angle glaucoma cases, but a huge amount is also pseudoexfoliative glaucoma, which we see quite often in our area, more often than it should be represented in middle of Europe. The mean age was 69 roughly, and the baseline visual acuity was not that good, 1.4, as it is most often when you start adapting a new procedure, at least in my personal experience, I try to start doing procedures on eyes which don't have a very, very good vision. And later on, when I know more about the complications and the safety of a procedure, I feel more comfortable to go on to eyes with better vision doing surgeries. The baseline IOP in these eyes was a little bit lower than 22, and they were on roughly 3 medications in the beginning. And there were moderate glaucoma cases. So looking at the baseline data and the data that we collected at 1 day, 1 week, 1 month, 3 months, 6 months, 9 months, and 12 months, we could see that the pressure was lowered not on day 1, but starting on 1 week after the procedure. So don't be disappointed at 1 day when the pressure is still not lowered after you do MP-TLT. And the medications could be lowered only slightly, but at all time points, they were at least lower than at baseline. So we didn't fill up with medication lowered pressure, but we could see a real pressure lowering efficacy of the MP-TLT through the last time point of the data collection at 12 months. And the visual acuity did not change during that time. I know it was a retrospective chart review and that has some disadvantages, but that's like the real life data I wanted to show you from my first roughly 50 cases. If you look at success rates, and for these procedures, we defined success as an IOP between 6 and 21, so no hypotony, but still lower than 21, but also an IOP reduction of at least 20%. We found a success rate at 12 months of 88% in these eyes. So the micropulse P3 device with a Cyclo G6 laser system is a mobile device, which is really nice because you don't have to use it only at one point. You can use it at different clinics. We have satellite clinics and I sometimes bring the laser there. We have a children's hospital where I like to bring the laser when I need it. You can do it under topical anesthesia in the office or in a surgical setup. And taking that into account, you can avoid a lot of times a second consultation for a surgery. So if you see a patient and you indicate the patient and the patient needs its surgeon's its IOP lowering surgery quickly, you can do it immediately. The safety of micropulse TLT allows it early on in the glaucoma continuum. And that's a little bit different from the data I presented you. That was my first cases. Now I often do micropulse TLT in eyes with good visual acuity. And the efficacy of the micropulse TLT allows it for discussing as an option to postpone fistulizing surgery, not as an alternative because it's not as potent as a trabeculectomy, but sometimes if you want to shift the surgery a little bit on for a later time point, you can offer MP-TLT for the meantime. From our experience and also from the data that is published so far, we do not expect a lot of serious post-op complications. Thus, we can minimize post-op visits. So I don't see my patients at 1 day anymore. I usually see them at 1 week and 1 month after the procedure. And that's very important. If your patients are not living really, really close to you, but far away, you don't have to see them that often. And probably even the 1 week visit is not necessary. All material can be sterilized with alcohol, and the laser fiber is non-reusable, so you always have a sterile laser fiber. Especially in the pandemic times, it makes it really, really easy to disinfect the platform, the laser platform, and the foot switch, and have a new laser probe for the next procedure. Talking a little about anesthesia. So in general, when we do MPTLT, subconjunctival or subtenon anesthesia could be an option. A retrobulbar block works fine, it works with everything, but you definitely don't need it for MPTLT. We often did for the continuous wave cyclophotocoagulation something called analogous sedation with propofol and fentanyl, something to put the patient to sleep and something against the pain, which is very, very comfortable for the patient and very comfortable for us as well, but it's definitely not necessary for the procedure as well. And something I do as a standard of care as an anesthesia form for MPTLT nowadays, I call Topic Plus. Every patient, when they come to the OR, they get tetracaine drops, so a topical anesthesia 3 times. I can insert the speculum by that very, very easily. And then I use xylocaine gel, 2% in alcohol-free preparation, multiple times applied to the eye, at least for 5 minutes. Then I remove the speculum, and then I do the MPTLT in this topical anesthesia form. And for most patients, that's very comfortable and they don't feel a lot of pain. They can tolerate the little pain they feel. And only for a few patients, it was like that they said, well, the pain was uncomfortable. Additionally, consider preoperatively 1 drop of phenylephrine or brimonidine for vasoconstriction. And as I mentioned before, I shifted now nearly completely to this topical plus anesthesia form, which in addition makes it for me more mobile to do the procedure outside the operating room and without anesthesia backup. And even in the first 24 hours after the procedure, most patients do not require oral pain medication, which is also a huge difference to continuous wave cyclophotocoagulation. So MPTLT definitely is different from continuous wave cyclophotocoagulation in a lot of ways. In the recent European Glaucoma Society guidelines, MPTLT for the first time has been introduced. It wrongly has been mentioned under cyclodestruction because it probably isn't cyclodestructive. But micropulse laser cyclophotocoagulation made it there, and the indications are as well refractory glaucomas, but also when filtration surgery or glaucoma drainage devices are likely to fail, have failed, or are not feasible. My experience with the new REV2 MP3 probe, so the new hand probe, the advantages and the safety on that. So first of all, if you look at it, the very, very big difference you have is the long and thin stem, the foot plate, which is slightly bent and curved. You have the bunny ears on one side that go towards the limbus, and the other side, which is flat, goes towards the lid. You do not need a speculum if you use the MPTLT hand probe, the REV2. The stem gives you enough access for the eyelid to see the limbus around the area where you want to treat. You orient the probe with the bunny ears towards the limbus. Make sure that the probe is in a liquid interface, and I come back to that later. Make sure that the probe is in contact with the globe. It's basically, if you use a pen and you write your signature on a piece of paper, the same amount of pressure you need to guarantee that the device with a laser fiber is in contact with the tissue you want to treat. And there's a little bit of variation and discussion about that, how many time or how fast, or better, how slow you should swipe doing your passes. I recommend at least 10 seconds. Do it slower if you want to have better results. That's what we get at the moment, 15 seconds or better, even 20 seconds per swipe. And the settings can also vary between 2000 megawatt and 2500 milliwatt, 50 to 80 seconds per hemicircumference, and the duty cycle is set to 31% with the machine in general. And If you see on the bottom left the picture, we orient the bunny ears exactly at the limbus position. You go in your hemicircumference, either the lower or the upper one, and curve around slightly. Avoid the 3 and 9 o'clock position with the long ciliary nerves, because you don't want to increase pupillary defects later. And on the right lower side, you see with the bent foot plate, you actually have the surface of the globe matching to your hand probe the whole time. And going back to the liquid interface, if you see the video on the left, that's the generation 1 hand probe. If you have it outside of water, the laser beam is spreading. If you have it inside the water, inside a liquid interface, the laser beam is nicely narrowed with parallel laser energy coming out. And that's why you should be having a liquid interface, methylcellulose, for example. And in this fluid channel, you see on the right in the foot plate, the methylcellulose will stay in, and in the middle of this fluid channel, the laser fiber is coming out of the hand probe. And that way you always have your laser energy focused on a single spot and not spread over a wide area. Looking at a procedure from Robert Noacker here, you see without a speculum, with a thin and long stem, you have enough access to the globe. And if the patient's like here is looking in the opposite direction, so when you treat the superior hemicircumference, the patient looks downwards a little bit, you have great access and great visibility during your treatment period. So just to summarize that, perpendicularity on the sclera is much easier achieved compared to the prior version of the probe with the REV2. As a result of the good visibility of the position of the probe to the limbus and the perpendicularity on the surface, probably less variation in the treatment location is achieved, and probably thus I expect more stable treatment results we will get with the REV2 in the future. The complication rates in general are pretty low. You often see a little bit of a mydriasis if you compare the non and the treated eye. Usually it disappears in a few months, up to 6 months. You see a little bit of inflammation, Tyndall, for example, less cells, and that Tyndall can persist also for a couple of months, so don't be afraid if you recognize that. And I say thank you for your attention.